Mechanisms of failure in total knee arthroplasty. We're all familiar with this classical paper by Sharkey, which showed that we have either late or early complications in total knee arthroplasty. Most commonly in the later phase, we see polyethylene wear and loosening, and of course infection is probably the most common reason for failure at an early stage. The registries, when you look at it, they actually look at it from the same manner. You see aseptic loosening and wear as probably the most common reason for revision. Secondly, infection. What surprisingly still is, that's why I did put a question mark, is the matter of revising if there's pain. In my opinion, that's a difficult thing. You see all registries have different, let's say, mechanisms of failure. So that's still under debate, is when you revise and why you revise. So if you look at the diagnosis of a patient who comes into your clinic with an unhappy knee and you have to think about the mechanism of failure, there are probably 1,001 reasons why it's not doing as good as it should be. So how can we cope with that? If you look at literature, this is the list I came up with. It's all written about how you try to analyze it and what's the mechanism of failure. Pain, first of all, in my opinion, is something which you should be a little bit reluctant about when you start revising. First of all, I think it's not the diagnosis, but it's a symptom. And we know that from an old paper from Hungerford that revision without a diagnosis is probably unsuccessful. Secondly, and this is a Scottish paper, came out in the JBJS showing that if you have unexplained pain, probably if you just wait, in this case for 5 years, 50% will be improved. So if you don't know the cause, do not revise. We all know this. If you have a patient coming in with this total knee arthroplasty, it looks fairly good. If you look at the pre-op x-ray, this is the reason why it didn't work. So remember that if patient selection is very important if you talk about mechanism of failure. Failed conservative treatment after a total knee arthroplasty surgery has been performed, try to exclude other sources of pain like the hip and the spine. So this is what we do in our clinic. We make it a, let's say, one-stop diagnostics. We start, of course, with a thorough history and examination. Then we make standardly AP lateral and skyline x-rays, long-standing alignment, and CT scans. We do a CRP and an ESR in all our patients together with an aspiration or biopsy. And then we decide on further treatment. In only less than 5% we make additional investigations like fluoroscopy or stress x-rays. And by doing this, probably over 90% of the cases can be diagnosed, which of course is what we hope for. So if you analyze the most common reasons of failure, as I said, both in studies and in the registries, you see infection, aseptic loosening, and polyethylene wear, instability and malalignment are the most common ones. Rule out infection is, of course, step one. I will discuss it in my next paper, but this is, of course, the first step you need to do. Secondly, you look for aseptic loosening or polyethylene wear. From a history perspective, it's important that if a patient has been satisfied for a period of time, that's a very important starting point. They mostly have startup pain initially, walking pain as loosening progresses, and it's usually better at rest. Sometimes there's some effusion and swelling or secondary instability. If you look at the radiographic findings, it's important to start with sequential x-rays, to just look at it, that the x-rays a few years before the x-ray you're actually looking at, it will show you if there's progression of the implant position or not. Changes on the bone interface and the prosthesis, of course, and look for radiolucent lines. And in our clinic, we are with a very low threshold, make a CT scan to see whether there's loosening around the prosthesis and whether you have, of course, reasons to think of bone loss already. What about instability? Sometimes instability is a fairly easy diagnosis. If this patient walks into your clinic or you see an x-ray on the other side, it makes it easy. Unfortunately, instability is much underdiagnosed. I think a lot of patients have a knee they can't trust and some infusion, which we call mechanical effusion. It means that they have problems descending the stairs, and especially anterior knee pain and an AP unstable CR implant is not uncommon. Try to get the information on the status of the ligament and test the knee throughout the range of motion to get adequate information on the ligaments and look if the deformity and the ligament is correctable and whether there's an endpoint or not. If you still have not enough information whether it's unstable or not, you can use fluoroscopies. In our hospital, we have a low threshold in using these stress x-rays, which you can both use in a medial lateral fashion, but also AP, as you see here. These are flexion x-rays, which you can also make with a stress device, which was actually invented by Romero in the Schultes Clinic in Switzerland. And it will give you information whether the lateral collateral is competent and whether the opening on the lateral or medial joint line is too much. Malposition, of course, is also a big issue. We've heard already this morning that sometimes it's not easy to align the knee properly. Most patients who have a malalignment or malpositioned knee, they have the problem that they have never been right. Often have a secondary stiffness or arthrofibrosis, and they claim they have a different position of the foot or leg postoperatively. And remember, it's possible in both the coronal, sagittal and axial plane or in combinations. And it can sometimes be very difficult to find in a clinical fashion. Secondary, it can lead to instability. Long-leg x-ray, we heard about it this morning in all painful total knee arthroplasty. If you look at this x-ray, it looks good. Unfortunately, if you make the long-standing x-ray, you see that this, unfortunately, is not a well-aligned knee, so remember that. Radiographic findings, as I said, AP lateral and skyline view, make CT scans when you have a maltracking of the patella, look at the component position and the size of the tibia and the femur, and look at the joint line and the slope of the implant. Important, if you make a CT scan and look for malrotation, especially axial malrotation, try to match it with the clinic. So if the clinic is different, look again on your CT scan, because measurements on a CT scan after total knee arthroplasty are not that easy. What about the threshold? We've heard about it this morning. I also suggest you read this paper which recently came out. It's a literature review about what we actually need to aim for, both on the coronal, the axial and the sagittal plane, and it will tell you a little bit what the normal values are which you are actually trying to aim for. And of course it's depending on the implant whether you put tibial slope in or not, but overall this will give you the information you need. Why do we all need to have this diagnosed? Because I think overall the importance of the preoperative diagnosis is very important in your patient information. Because if you want to re-revise, the patient will ask you, what are my chances of success? And unfortunately, so far, this is a paper we had out last year, trying to look at the prospective database of the outcome of patients and the reasons for revisions. And you see the best ones are still the aseptic loosenings one, moderate instability, malposition and infection, and worst, unfortunately, the stiffness related to a malposition or instability. So in summary, pain itself is not a diagnosis. Try to standardize your analysis for failure mechanism, and remember that the diagnosis is a very important factor to predict the clinical outcome before you start revising, and it will give you information you need to give the patient before you start doing your revisions. And therefore, I think we need more prospective studies on diagnosis versus outcome. Thank you very much.